Alright, in the last set of slides we just introduced basic anatomy of the acetabulum. We talked about some of the nerves and vessels that you need to be aware of. Talked about where you need to be worried about damaging the medial femoral circumflex artery. Right, when you do your posterior approach, you need to also be very aware of the location of the greater sciatic notch. And then in the very beginning we talked about the basic concept of the acetabular columns and how you should look at the acetabulum as this sort of inverted Y, okay, with anterior posterior columns. So now let's talk a little bit more about radiographic evaluation of the acetabulum. Keep in mind that radiographic lines on plain X-rays are where, or the bone where the X-ray beam is tangential to its surface, and you get shadows, and a lot of things you see on the X-ray in the pelvis are not actual structures, but they're just sort of these shadows that are created, so to speak, oftentimes when an X-ray beam is tangential to a surface. Now, you may want to pause your video at some point and get a good long look at this. This is a very nice schematic, very detailed, but this is right out of the Letronel and Judet textbook on fractures of the acetabulum. I'm certainly not going to go through all of this, but this is basically showing the acetabulum viewed from an Obturator oblique X-ray as shown on the right, and all the features of the acetabulum that you should potentially be aware of, knowing what corresponds to exactly what on the X-ray, for instance. So in their textbook they've done a ton of work to show us what we can interpret from the X-rays, I guess the best way to put it. So basic radiographic evaluation includes an AP pelvis X-ray, Judet views, which are oblique views, right? These are our Obturator and Iliac oblique views, okay? CT scans, which are critical for looking at the posterior part of the pelvis, but also in the acetabulum help to show comminution, marginal impaction, for instance, and also help us to better understand fracture patterns. And I think 3D simulated, CT simulated X-rays and 3D recons, I think, are really helpful in this day and age. And then sometimes you need dynamic stress exams, especially with small posterior wall fractures. So the AP radiograph is basically shot with the patient laying supine and just an image that is perpendicular to the patient lying supine. Alright, so here are a lot of the landmarks and what they correspond to on radiograph. The iliopectineal line, and these are labeled here, right? So iliopectineal line number 1 is this number 1. All right, so you might want to take a few minutes, take a look at this picture to understand what corresponds to what, and if you have to, you can go ahead and pause. I'm not going to point each one of them out. They're all numbered here. Okay, that's 3, 4, 5, the anterior rim, 6, the posterior rim. Now on the AP pelvic radiograph, the iliopectineal line, it's interesting, you'll have to sort of look at a model maybe to better understand this, but the iliopectineal line really is not one contiguous structure anatomically. It looks like it on X-ray though, right? So the anterior 3/4 corresponds to the actual pelvic brim, casting a shadow against much less dense, pelvic contents. And then the posterior 1/4 of the iliopectineal line corresponds to the lower half of the internal surface of the sciatic buttress and the roof of the greater sciatic notch. I'll show you this in a second. The ilioischial line corresponds to the quadrilateral surface. Okay, so Again, they're these sort of tangential lines, but the iliopectineal line from here to here represents the pelvic brim, and then in this upper portion it represents that part of sciatic buttress and the greater sciatic notch. Two discontinuous features anatomically, right? They're not the same thing. Okay, and here's the ilioischial line. Okay, so here's how the ilioischial line is going to be projected on X-ray. And another landmark you need to know, maybe you're familiar from your total hip arthroplasty templating, is the radiographic teardrop. This is comprised of multiple anatomic structures to help form this apparent teardrop. The internal or medial limb is the outer wall of the obturator canal. The external limb is the medial 1/3 of the cotyloid fossa, and the inferior border is the isthiopubic notch. So here that can be shown here, right? You can see that medial limb being formed to the left here, and that quadrilateral plate and that surface where it becomes tangential to the X-ray forms that medial border of the teardrop. So here it's shown very nicely. Okay, there's that radiographic teardrop. So cotyloid fossa here, okay, and then the quadrilateral surface here. Okay, and that forms your teardrop as shown here. Now, the acetabular roof is very critical. This is the part of the acetabulum you really have to make sure is nicely reduced. It's representative of the superior weight-bearing area of the acetabulum. Okay, the anterior and posterior walls are the sort of lateral extensions of the articular surface. So on an AP radiograph, for instance, that sourceal, okay, so sourceal, the roof is also known as the sourceal line, is demonstrated here, and that anatomical roof extends about 50 to 60 degrees in that region right there. Okay. Now, on an AP pelvic radiograph, it's very helpful to understand associated pelvic ring injuries, bilateral acetabular fractures, femoral head fractures. These are just examples, right? Fracture displacement, congruency of the femoral head and the acetabulum. You can see all this on an AP. Judet views, which are these 45-degree oblique views, these kind of highlight the acetabular columns. Okay, and if you want to have a really good Judet view, you have to be really rotated to the point that the coccyx tip lies above the center of the femoral head. And on that schematic I showed many slides ago that I said was from Letronel's book, that I said maybe you want to pause and look at this, that kind of showed this concept very nicely. Alright, so again, think about how the acetabulum looks as viewed from above, and the acetabular fracture lines are again demonstrated by these sort of tangents. So the obturator oblique, if you have to, you can rewind, kind of see that image in the last slide, is if you imagine it's the right acetabulum will be right side up now. Okay, so the coccyx is centered over the ipsilateral femoral head. The obturator foramen is in profile. Therefore, this is called the obturator oblique. You see, you're looking right down the obturator foramen, so you get that sort of big oval shape looking at you. Highlights the pelvic brim, the anterior column, the posterior wall. Okay, and certainly it demonstrates how congruent the femoral head is in the acetabulum. So if you're looking at the right hip here, then this would be an obturator oblique of the right hip, right acetabulum, the right side tilted up. Okay, here's the patient. They got a wedge under the left hip, right? So left hip. In this case, they're showing an obturator oblique image of the left hip. You have the model or drawing on the left, X-ray in the middle, and here you have the patient actually being positioned. Okay, obturator oblique X-ray. Whereas the iliac oblique, the injured side is down. Coccyx is centered over the contralateral femoral head. The iliac wing is in profile, and here you see the posterior column, anterior wall, posterior border of the innominate bone, and quadrilateral plate. Okay, so if you are looking at the right hip here, this would be an iliac oblique. Okay, so the iliac oblique is going to look something like this for the left hip. Okay, so instead of, the obturator foramen is now in here, and now you sort of see a straight-on view, not exactly because it's a curved surface, but you sort of see the very broad picture of the iliac wing. Okay, and here this dotted line here shows the posterior column, or the ilioischial line. Okay, very nicely shown here, and the anterior wall of the acetabulum. Okay. What about CT scans? Well, CT scans absolutely help to show acetabular wall fractures, intra-articular loose fragments, okay, shown very nicely right here. Here's a little loose fragment. You may not see that if you just got x-rays. Marginal impaction, it's a very important concept that you need to understand, seen oftentimes in posterior wall fractures. CTs help show the degree of fracture comminution, where the femoral head is, if there are femoral head lesions or a femoral head fracture. Right, and also help to critically show you if there's joint congruence, and also show the SI joint very nicely, which and sacral fractures, which may not be seen very easily on plain radiographs. The 2D CT scan, things you need to understand here are picking up on fracture lines that you don't necessarily see in X-rays, understanding the orientation of the fracture lines, and recognizing the vertical portions of T-shaped acetabulum fractures, understanding how fracture fragments are rotated. Here's some examples of what you may look for on an axial CT scan that correspond to fractures, and making diagnoses of fracture types or classification from axial CT scans is very difficult, and to some degree you need to use it in combination with plain radiographs or 3D recons to really understand a fracture pattern. But here's an example. Okay, here you can see there's clearly a fracture line. I'm going to come back to this AP view. Perhaps it looks to appear to disrupt both columns. Here's a, right, think about it, right? This is the obturator oblique view of the right hip. Okay, and you have a fracture disrupting the anterior column here. Okay, clearly there's a fracture here. And then here you can see it looks like there's a fracture through the posterior column, right? The posterior column should be here, and it looks like there's a fracture right there. And the head is not congruent, right? The joint, the sourceal or roof is here, and the head is basically here, so that is not congruent. You get a CT scan. Here you can see that there's multiple fracture lines. It appears to be a transverse fracture here. There's another fracture here. It looks like the posterior wall is involved. So a lot of information from a CT scan. What about 3D recons? There's different rendering techniques. There's surface rendering, which there's some limit in the amount of detail, but it does allow you to get a nice three-dimensional picture, and I think it can be very helpful for classification. Okay, so here's that fracture demonstrated here. You can see it appears possibly to be a T-shaped with posterior wall component. Okay, the vertical limb of the T is minimally displaced, but I would say that's what it looks like. Okay, large displaced posterior wall fragment here. Now, volume rendering gives a little bit better detail, right? So if you look at this, you get sort of a better idea. You can get some sense of the sort of shadows that you may see. You get a better impression of the fracture lines. Here you can see there's a fracture line here, there's fracture lines here. You get the impression there's some comminution here. You can remove the femoral head, for instance, and get a better look. And now we also have these sort of simulated x-rays, where you get these simulated Judet views, essentially, which make it look somewhat like x-rays, right? And I think for a lot of the purists, they feel that these may be better replacements for standard x-rays, because they really do look like nice Judet views, and that's what people are used to seeing. Alright, so this is just sort of the technology difference between volume and surface rendering. So just last word on imaging is stress radiographs, right? So a lot of times you have to evaluate the hip joint stability after you have these small posterior wall fractures, okay? You can do an exam under anesthesia after a small isolated posterior wall fracture and try to get a better impression of how stable it is. So what do? You put the patient supine on a radiolucent table, hips in full extension, neutral rotation, and then you slowly flex them up, and you apply some progressive manual force. You use your body weight. You axially load the hip, so shown here. I'm going back a slide. You look at the hip on C-arm, and you do this on an AP as well as an obturator oblique view, because that's the view that kind of nicely shows you the posterior wall, right? If it's stable, you keep adducting and internally rotating it. And if you see posterior subluxation, that means it's unstable. So here you can see under general anesthesia, you have an obturator oblique view. You can see the hip is flexed up and congruent on the left, here, right? Nice congruent joint. And then here you can see that there's subluxation with axial load. So your standard initial radiographic evaluation is an AP pelvis, Judet views, 2D CT scan. Sorry, I'll go back. But I think you can very easily these days get a 3D CT scan, and I think that can be very helpful. And then stress views really are for that posterior wall questionable fracture if you're not sure if it's absolutely in need of operative fixation or not. Alright, I think we'll stop there for now, and then we'll talk more about classification in the next talk.